So greetings, friends and followers. This is Nurses Talking. I am Del Barzi. And as always, if you like what you see and hear, subscribe. Leave us a comment. Let us know what you think. Here on Nurses Talking, we speak to nurses anywhere in the world and at any stage in their nursing journey, from students to retirees and anywhere in between. Today, it is my great pleasure to welcome Kirby Williams. Kirby is a psychiatric nurse practitioner. She's a coach, she's a mentor, a self-care advocate, speaker, educator, entrepreneur. She's the founder and CEO of PMHNP Source LLC and PMHNP Psychiatric Mental Health Nurse Practitioner. So welcome, Kirby.
Thank you, Dale, for having me on. I know it's a mouthful with our acronym, but yes.
That's okay. We'll get through it.
Yes.
But thank you very much for doing this. The more I do this, the more I understand and appreciate how fortunate I am to speak to all these diverse nurses doing all these different things. So thank you.
Yeah.
But firstly, why are you a nurse?
Great question. So I first wanted to become a nurse when I was age 5. I had asthma and a lot of allergies. So I had luckily I didn't have like a lot of hospitalizations, but a lot of like doctor's visits, specialist visits at a young age. And what I noticed the most was I pretty much became a family with the nurses there. Like I can't remember their names, but I know like what they look like. I can like see their faces. And I was like, man, I really want to be like them. That is what, I remember the feeling, that they gave me. And I was like, man, I really want to do that for other people. I really like that I can feel at home is a strong word for a doctor's office, but you know what I mean? You don't feel scared, as a kid, you don't feel scared or worried or anything like that, even though I was going through, different battery of tests or new medications and this and that. So that's really where it came from. And I was like, man, I just want to do that. So since I was age 5, I knew nurse was what it was at.
Oh, wow. So having wanted it from that early age, did you go, like directly to it, or did you at any time kind of like divert into something else?
No, directly into it. Directly to it. Even when I went to college, there's some colleges and universities that have a direct into their nursing program, and some you have to, do undergrad and then you got to apply for the nursing school. So I only applied for schools that had direct into the nursing program because I said I'm not, I'm not playing. Yeah, I'm not playing. Ain't no need to do nothing else. I'm trying to, and so that's what I did like that about choosing that school that I went to specifically. I was like, I know what I want to do, so I don't want to waste any time.
You were laser focused to plan A, B, and C.
Yes, exactly.
Okay, all right. But then, when you got there, when you became a nurse, going through nursing school and become a nurse, was it what you thought it was going to be?
That's a great question. Let's see. I think that some things, yes. So I remember working on my first unit I worked on. There was such great teamwork, I will say. And that's what I thought about, nursing. I was like, man, such great teamwork, things like that. So there's such great teamwork with the people that I worked with. I was probably maybe 1 or 2 new grads on that unit at the time when I started. And I found that everybody was very helpful, from the what's it called, the unit secretary. It was an inpatient hospital. So the unit secretary to, people who were doing like dietary, everyone was just so kind and helpful. They knew I was new and was, helpful. And I was new to the city that I moved to. So they were just helpful in all kinds of ways, not just in my career, but in my social life, and just, making sure I knew where to go for things, knew where to find things, as a person who was a new grad, but then also just new to that area too. So that part I was like, yeah, this is what I was looking for. I think the parts that weren't, like exactly what I, expected was probably the high, which I know is still a thing, the high acuity of patients. We talk about the care needs and then the expectations of, nurses. I don't think I didn't really fully see that and get that in clinical, because you're always working with a nurse and, your clinical instructor. So you have like help when you're in clinical. So I was like, oh, wow, this is really, a heavy lift emotionally,
Yeah.
physically,
Yeah.
all those things. Yeah.
Yeah. I can imagine. So did you, what kind of areas did you work?
So what type of settings? So my settings were focused in med surg, actually. So the first unit, it's a level 1 trauma center in the desert. I was in Phoenix, Arizona. And so it was a lot of trauma surgeries or people who had a traumatic accidents, and then on that unit for surgery or whatever injuries they had. And then other units were med surg units that were similar to that. One was a medical cardiac unit that I was also on as well. So it was focused, as a registered nurse, happened to be focused on med surg, mostly because that's what they told me to do, right? What they tell you to do when if I'm being honest, if that's, they were like, go into med surg, start there. So I was like, okay, I'll do it.
The world will fall and implode if you don't.
Right, exactly. So I did as I was told. So I did that.
Though, what made you gravitate toward mental health?
Yeah, so a couple of things while I was doing as I was told in med surg. What I noticed about in med surg, especially at that first unit I'm thinking about, which was like high acuity traumatic incidents, people losing limbs, just having very traumatic experiences, is that a lot of my patients were also young. So I would say under 30 most, and these are persons who are, and most actually were like in their 20s, losing limbs, maybe had lost persons in the accident that they were in. Things like that were happening, or losing some kind of functionality, even if they still had the limb. And I noticed like, okay, this is a person who's 22. I can't remember someone specifically, 22, motorcycle accident, lost their leg, basketball star. And like what comes after that for him, for example. And I was like, I don't know. And I don't even think we've even talked about it, with like treatment team and things like that. I don't think we even talked about it. And I was like, well, that's weird, because this is like 22-year-old person, this is his life, because I've gotten to know him. He was there for a while, but gotten to know like, oh, this person was a basketball star. And that was, this was his life and just beginning his life. Yeah. And so I really leaned to like, what could I, do? Because I really feel like there's a hole there, not just with that gentleman, with the other persons as well, but there was that hole there. And I actually had thought about, maybe I should go back and be like a therapist, like a LCSW or licensed practice, licensed nurse, no, not nurse, counselor, professional counselor. Yeah, that's what I had thought about. I was like, maybe I should go into that, because I really feel like that's a missing piece. Maybe that's a piece that they could bring into hospitals like this, and that, that could help. And then, I was just looking, about like, well, what else could there be in nursing? What other possibilities? And that's when I found out about the psych mental health nurse practitioner degree and certification. And there were actually at that time a lot of advanced practice nurses in psych who were doing counseling. I know it's a little different now, but like that was a lot of focus back then. But when I got my degree, that was where a lot of the focus was. And I was like, oh wow, that seems like I could be that missing piece. I would, could use my nursing experiences and what I know. And I thought there was some way that I could merge like, medical trauma, things like that with psych. That was kind of my original kind of plan. Like, how could I do that and be the fitting missing piece for some of these either hospitals or even rehabs or things like that as well?
Yeah. That's huge. So I was going to ask you, what would you like to see change? What would you, but you just articulated one thing right there.
Right. That intersection, yes. That intersection specifically, yes. I don't know for a fact, because I don't work in hospitals now, but I'm pretty sure that gap is still present in most or a lot of places. And so that would be one thing. And I think all trauma hospitals should have, whether they use a psych nurse practitioner or they use a therapist, some kind of mental health clinician, I think should be on staff, and they don't have to be just at one, one unit. They could be floated throughout the hospital,
Mhm.
and
Mhm.
making sure that, especially when they go home, because thinking about the gentleman I gave you the example of, that there's that piece, because there wasn't, I remember, we go through discharge
Yeah.
instructions and things like that.
Huh.
There was nothing about that. And I was like, well, this is, so like someone
Which
could
was
make
actually
sure.
a setup for a huge failure.
Right, exactly. So that's one thing I would think too, like some kind of mental health clinicians, or a team of them in the hospital who could, and not just like the I know they have, a lot of places will have a psych consult
Yeah.
team, and
Yeah.
though which are good too, but I even think even more detailed than that, because consult service, they roll in. I know they got a lot of people to see, but maybe someone who could help on the discharge side.
Yeah. Talk about that concert service for a long time. All
Mhm, mhm,
right. So, in reading about you, though, one of the things that you talk about is that you wanted to address things like implicit bias
mhm, mhm.
and racial bias in healthcare.
Mhm, mhm.
What, I'm not saying you shouldn't, but why are you taking on this huge
I know.
why?
This huge, yeah, and it is huge. And thank you for even saying that piece, because sometimes people will talk about it, I'm like, this is huge, this is a huge thing. This is not like, it's not small at
What
all.
is
And it's gonna take
it?
a lot, and it's gonna take all of us, right? Um,
Yeah.
so one of the things that I noticed when working in, once I moved into my advanced practice role, which I've been in this role as an advanced practice nurse now for 12 years. So
Mhm.
now that's been more than double the time that I was a registered nurse. So I've been
Mhm.
in mental health for a while. And one of the things that I had noticed was and this was like even before looking at the research, this is just like what I saw with my own eyes, just some
Mhm.
things that I saw as it pertained to Black patients, and usually it's Black patients and then white patients, that there were
Mhm.
some differences there in number of medications on like the person's regimen. And this is in mental health. I want to speak to mental health specifically now. So, number of medications, and then also types of even diagnoses that I would see, even though I'd see both patients and I would say like, these symptoms are the same, but these diagnoses are
Right.
very different and the
Mhm.
regimens are very different. And so I started to just see that. And I said, that's just what I'm seeing. But we're nurses, so we love that EBP, advanced evidence-based practice, right? So I said, let me just take a look at what the research says, not just base it on, maybe the
And what
experience
you
I'm having.
mhm.
Yeah. And so once I did kind of look into that as it pertained to mental health, I saw that there's research that goes back. I think the furthest research I saw that to be consistent about those kinds of differences were from the 1980s, and that had to do and relate to, it was Black men specifically receiving higher doses and or multiple antipsychotic medications more than their white counterparts, even for the
Mhm.
same diagnosis and same
Mhm.
symptomatology level of symptoms,
Mhm.
things like that.
Mhm. Mhm.
And so I started, to do a little bit more digging in there and said, I'm ready for a point to start sharing some of this information as well. Because one, I know it's not just what I'm seeing. It's
What you,
actually things
yeah.
that have been, that have been
Mhm.
seen, have been talked about. And since that was the 1980s, and I think I started noticing this like real head on about like 2016, 2015. I said,
Yeah.
it still appears to be happening. So
Yeah.
let's speak to it in a very intentional way. And so that's why I started doing that. And I do that probably usually about 3 or 4 times a year. I'll do a presentation on that. I just did one
Mhm. Mhm.
earlier this month, earlier this month,
Okay.
on that specifically. But yeah, usually I'll do a few on that, because I think it's important to tap into, it's important to talk about. And the more you talk about it, the more you get others to talk about it, then the more it can have the possibility of change.
Yeah. 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 Exactly. Exactly. And I hear you, and I know what you're saying, because I if you've been in healthcare in all kind of capacity for any more than 5 minutes, you actually do see it,
5
whether or not
minutes.
you pay attention to it or not. You actually
Yeah.
do see it.
Mhm.
And I realize that the very often um, I don't want to use the word perpetrator. I'm looking for a different word.
I gotcha.
But but the people who from whom this comes actually don't realize that they're doing it.
Right.
Right. And so the education needs to be just that education, not necessarily accusatory, not necessarily anything, but just that education.
Yeah,
Yeah.
no, agreed. And actually, like in some of the, as I've been doing more research now on the lens of interventions that can help, one of the things they said, and you just spoke to it, is that if something is like very accusatory or very like that doesn't change bias. I mean, if it did, great, but it does, like they just are like, that doesn't change it if it's very accusatory or it's very like heavy, like you know, or you know, that how that actually doesn't impact bias. It doesn't mean you shouldn't speak to it if it comes up. I didn't say that. It just means that it being on that, you know, kind of defensive of it, could cause the person to clam up, you know, so much that then they're not even open to the education that may be provided.
Exactly. So you talked about also in that you talked about the overprescribing. And I see one of your things is deprescribing.
Yes. yes, it is.
You know, and that really is again such an important thing, because we just pile things on top of things and then we turn it around and blame the patient for the side effects, for the manifestation of the side effects. Let's put it that way.
Right. Agreed.
Which, you know, my dear. Okay. Again, I could go on about that for a while. So anyway, moving on a little bit. You are founded a company to mentor nurse practitioners. And I'm wondering about that space. What made you realize that there was a space for this? Clearly, if you needed to do that, then there was they're coming into it floundering a little bit.
Right. The nail on the head there, Dale. Yes. yes. Coming into it floundering. So when I started my journey, I became a psychiatric nurse practitioner in 2011. And at that time, I know it again looks different than the space that we're in now, where there are a lot more nurse practitioner programs, a lot more, you know, people maybe advancing their degree in that way. At that time, especially for psych nurse practitioners, there weren't a lot of programs. Actually, I was on the East Coast, and where I was in DC, Washington, DC at the time. There was only two that were close to me. One was 2 hours away, and the other was actually at Yale in Connecticut. Actually, you know, it was so those were the only two that were like reasonable, you know, from me. And there were no online programs in education at that time. So so there was already that. There wasn't a lot of us and a lot of programs, so there weren't a lot of maybe educators and support and things like that. So when I graduated, similar thing, I had a really great collaborating physician, so I'm always thankful for him. But like anyone who's working in healthcare, people only can give as much as they can give, because they, have things that, they have to do as well, and responsibilities they have outside of assisting or helping me. And so one thing that I noticed when I started was it's like there was that kind of gap. And with nurse practitioners, at least, my experience was like, you get about a week is really that's strong, but you get about a couple of days, maybe a couple of hours of orientation, and then you are boop lift off. And then of course I always thought, well, maybe it's just my experience. I was working at an inpatient hospital, so there's a lot of people around, so maybe they thought, okay, well, you're going to be around a lot of people anyway, you can always ask questions. But then as I, continued my journey and started to help to precept other nurse practitioners, and then kept in touch with them after they graduated, they were in all kinds of different settings that I didn't start in, and were having the same experience. And then, I became, like, I would say, a de facto mentor and, coach for psychiatric nurse practitioners in the area where I am, because I had been doing it for so long at that time. I precepted a lot of nurse practitioners, psych nurse practitioner students. And so I was doing it. I was already doing this business, but
Yeah.
it wasn't a business at the time. I was already doing it. And someone had asked me in 2019, you know, if I was to pivot or do something, what would it look like? And I described this business. It didn't have a name, but I described this. But I was like, I don't know how I would get that out to people besides the people that I, know, and I've already been working.
Yeah.
How do I get that out? And then the pandemic happened, and then I had a baby, life. And so then I had a chance again to think about that seed from 2019 in 2022. And I was like, okay, it's still on my mind. I still think maybe some things are possible with that. I'm still doing the work. I'm still doing the stuff. People are still tapping in, and I'm helping to mentor them. And so that's when I started on 2 social media. I started on Instagram and LinkedIn. And I said, I'm going to do this for 3 months. And if it flops, if nobody reaches out to me, if nobody's like, oh, this is really good, thanks so much, or nobody really feels like aligned with it, then I'll just close them down and I'll act like it never happened. If, nobody, I was going to do it. I already had a plan in my life. That's it. But what happened is that actually in like the first 3 weeks of being on LinkedIn, people started reaching out to me about services and getting mentorship and getting support in their career and wherever they were on their journey as psych nurse practitioners. And I was like, oh, this is for real. Okay. Okay.
All righty then.
Right. Let's do it.
Okay.
Yeah.
So you say you're a self-care advocate.
Yes.
What does self-care mean to you?
Yes, that's a great question. So to me, it means just tapping into activities that are rejuvenating to you. And I leave it at that because that may not be getting your nails done, and that's okay.
It's okay. That's okay.
It's okay. It may be like organizing your desk. And for some people, that rejuvenates me. So I'm like, it feels like less clutter, less. So it could be any of those activities.
Yeah. And I specifically asked that question because I want us to think about self-care, because as nurses, sometimes we don't. Well, often we don't. And B, as you just said, it is so different for each person. Not just for each person, it's so different for the same person on different days.
Right. That's true too. Yeah. That's true. I need to say that more too. It could be still you, but it's different. It's a different day.
It's different day to, I'm in a different room today.
Yeah. Yes. No, that's good. That's good. And one of the things I talk about, I try to express a lot, especially and this is probably for all nurses and nurse practitioners, to be very honest, which is one of my things that I really advocate for us to do when it comes to self-care is setting and enforcing boundaries. And that's professional, personal. I think that's one of those, like, I won't say it's like unlocking the key, but I think it's such a powerful tool that a lot of times we don't lean into. I remember as a registered nurse, I was grabbing every overtime shift, because somebody was calling saying they were short. And though you want to help, what are the boundaries to yourself? What is the capacity that you can continue to take on, doing all those shifts? Because now you're working 7 days in a row, 12-hour shifts. Well, wait a minute, wait.
He just say 7.
Right. Yeah.
Yeah. And I it took me a long time in my own career, first of all, to even acknowledge the word boundaries. Implement boundaries, to stick by them, really, because I think it's innate in us that we just want to do.
Yeah.
And then our education reinforces that. And the way we're perceived reinforces that. And somehow it becomes a guilt trip if you don't do what everybody wants.
Right. Yeah.
No.
No.
No. And so we have to get there. So when you said that word boundaries, that resonated way back for me. Thank you.
Yes. And it took me a while as well to get to that place. And once I finally got to it, I would probably say about it's more recent, maybe a good solid 5 years ago, where I was really setting and enforcing on a consistent way. I mean, I tried to start before then, but actually doing it in
I
a
know what you mean.
consistent way. It was probably about 5 years ago, and I really noticed how it shifted some things for me and my career, and what I was able to do, because it really, and it was like the first thing I did at any new job. And I was like, the first thing you do is set boundaries. Yes. Yes. It's like, it's on the list. Is like, this is, and it doesn't have to be mean. I think for sometimes we feel like, oh, setting boundaries, it's so mean. No, it's just setting up the expectation. I think most people respect it and understand it. I never, never is a strong word, but I don't often get, any kind of negative, feedback from it. People are just like, oh, okay. I know she's not in the office today. I'm not going to hear from her today. Okay.
But I have to say this. I noticed this. It occurred to me maybe about 2 years ago, when I really started paying close attention. I think I'd been kind of setting boundaries before, but really firm boundaries. It occurred to me that setting boundaries actually marketed to us in a very negative way. And what I thought of was the way, for example, in movies, what came to me actually was like Mrs. Doubtfire, truthfully. When she's looking for housekeepers, and the housekeepers come and say, I don't do windows, I don't do Mondays, I don't do dishes, I don't do. It's like, wait a minute. It suddenly occurred to me, well, that is negative marketing of boundaries to me right there.
Right. Yeah.
And so maybe that's one of the reasons we find it so hard to do it, is because, it's been presented to us in a very negative way.
Right. Yeah, that's true. That's
very
true.
subtle, but very negative way. Anyway, what would you say if you could describe the most essential quality of a nurse in just one word? What would that word be?
Yeah, boundaries. No, I think that's good for us to have, but just the essential quality of a nurse. I really think it's two: empathy and compassion. But again, I always still think in my head boundaries, because I think there should, because sometimes when I say that, people are like, well, yeah, I got to be compassionate, and then that means to give all of myself over capacity, and I don't mean that by that. I definitely don't mean that. I just mean, being in hopefully standing in a place of understanding of someone's concerns, issues, exacerbation of their illness, standing in a place of understanding of that. And sometimes that could be, you talked about earlier about, like, we give all these medications, and then, have a complaint about the manifestation of those. But if we're able to stand in compassion and empathy of, like, okay, let's look at this medication list. There's 10 things on there. Of course, this person is probably going to be having an experience of some, because there's 10 things, something, because there's 10 things that they're taking, along with maybe anything that they're taking over the counter, let's say, with any foods they may be eating that are not as, healthy, whatever the case is. So just standing in a place of understanding of that.
Yeah. Not to mention all the other things that go on around them.
Right. And that too.
Dear. So, is there any last word you'd like to leave us with?
So that last word is, for real, boundaries. It's really setting and enforcing boundaries. And this is in your personal and professional life. I think it is so important for us, really anyone, but really as nurses, because I think you're correct in the way that we were taught, in the way that we were educated. It was, even if it wasn't said, it was kind of, undertones of, you give to your patient, you give to the, the parent, the family member, the support system of the, of the patient. That is kind of the undertones of it, even if it wasn't said. So really remembering that, you are treating humans, and you are human yourself. And so there's going to be limitations and all of that, because we are human. Right, we are human, so it's going to be limitations.
Yeah, indeed. On that note, Kirby, I cannot thank you enough for this conversation. It's been fabulous. Thank you.
Yes, no problem, Dale. Thank you so much for having me. I so very much appreciate you taking the time.
My great pleasure. My great pleasure.